So my name is Susan Bewley, and I'm going to tell you about a paper which I'm very disappointed because I talked with last night. So few of you have read, but maybe you will after the talk. So first of all, I'm going to start with my eminence, because, you know, we were all brought on eminence-based medicine. I need to establish my credibility. So first of all, you need to know, well, you don't need to know all these things, but I'm going to tell you about my eminence, then about my biases and interests, a little word on ethics, and then I'll tell you about the paper. So I went to Oxford in 1976 and specialised in maternal-fetal medicine. That's me holding a baby when I was younger. I've got a degree in law and ethics, and I was a consultant at Guy's and St Thomas's for nearly 2 decades. I've also worked as a forensic sexual offences examiner for 4 years, and I've co-led all the London Sexual Assault Referral Centres briefly for maternity locum. And my own personal research, if I'm in lane, I'm in obstetrics, and I did a lot of work on domestic violence and severe maternal morbidity, near deaths, and I've been an honorary academic at King's for a long time. So that's my clinical background. So basically, I don't know about the content, but I'm, shameless about that. That's not the point. I also want to say that you need to know a little bit about my personal interests as well. So I've been an honorary academic and an emeritus professor at King's College London. HealthSense is a 35-year-old charity which is for science and integrity in healthcare, and it's the scourge of complementary and alternative medicines, and also overdiagnosis, overtreatment, and what we hear about now, diagnostic overshadowing and disease mongering. The Sophia Forum is a charity for women living with HIV in all their diversity. I use those words carefully. And I also am a co-founder chair of the GLAD, which is the LGBT plus Doctors and Dentists Professional Association. I want to make it clear I am not speaking on behalf of any of these organisations. Very important for you to know that. So it's also very important to understand the money flows and the financial interests. So transparency is a necessary but not a sufficient condition to have proper scientific debates and policy making. And in the United Kingdom, we do not have a Sunshine Act. We do not know who is paying this doctor or this healthcare professional or this charity. Well, we do know who's paying charities. Sorry, I'll tell a lie about that. Anyhow, I'm an author of a paper in 2014 which was calling for our regulator to set up a register of interest as a probity matter, and we set up a voluntary register. So for many years, I have been using this, just like most academics do, writing about my declarations of interest. My declarations are separate from my conflicts. Someone else should decide if I'm conflicted. And I also want to draw your attention to a fantastic report called First Do No Harm, the Independent Medicines and Medical Devices Safety Review, which looked at 3 very long-standing scandals, an issue about iatrogenic harms to patients, a premature pregnancy test, valproate in pregnancy, which seems to cause many more problems than people admitted. It's still not black boxed, and it may even be intergenerational, and also urogenital mesh. So for prolapse. So sadly, and I've had a ringside seat on the assisted reproductive technology sector for 40 years as well, sadly, complications are spotted late, and we dismiss particularly female patients. So that's sort of very sad for trust. So now, if you want to know what's on the voluntary register, you can look me up. I'm /58. And at the moment, I'm only earning money because I'm retired from my pension and from working for NICE. We've heard a lot about NICE, National Institute of Health and Clinical Excellence, which has set global standards, along with, I think it's called IGWIG in Germany. The Australians have a guideline producing body as well. So there's a lot of these bodies around, but NICE is, I'm a NICE fan. And I've chaired many guideline development groups over the last decade, including those on intrapartum, and I chaired the UK's COVID management guideline, which is a living guideline as we were changing the methods. And I've seen methods change enormously over that time. I've also worked using MAGICApp, and I've been on guidelines with the WHO. So I've earned money from being a guidelines groupie. And I do occasionally earn money from lecture fees. Like today, I haven't decided what to do with it, and from royalties from the various books that I'm advertising to you here. So quickly now, just to think about what do doctors do? And this is something I think we've talked about whether this is a human rights issue, whether there are harms and benefits and so forth. But I think after a year of studying this, I came up with this little diagram, which is basically that doctors and patients are in a special relationship, which is underpinned by ethical values. But these come from different philosophical camps, and I think we need more help from the philosophers and not from the, Johnny come lately ethicists who may have written some very bad ethical papers. Doctors don't want to be unethical, and when ethicists tell us we've been unethical, we get very nervous. So ethics lifts the standards. We want to do our best for our patients, and we use research in terms of truth-seeking, but it's also boundaried by law. And when people say, oh, it's legal, what they're saying is, I haven't gone below the bottom, common denominator. So this relationship depends on trust. It relies on science. And we use a number of techniques, all of which can be harmful, and sometimes they're beneficial. And I will just say it again, I said it yesterday, but we like to think about categories. We give people labels. Labels are very dangerous. They're called diagnoses, and sometimes they're helpful. They're particularly unhelpful, I think, in adolescence. We communicate by listening, hopefully, and sometimes talking, using talking therapies. I think talking therapies need to produce their evidence base. And we prescribe poisons, aka drugs, from which we hope to extract benefits, because most drugs have multiple effects, and sometimes we gave, no, I don't get that, so I've got time. And surgeons perform assaults on patients. What I do with a knife would be an assault if it was done in the street to a stranger. But what makes me confident about these things are what I learned, what I read from the books, what I read in the research, what my peers say, and the feedback I get. The very same things cause bias that I thought was reliable. So the issue here is that we need to think about the ethics, and we need to think about the third parties who are looking at us. I can be convinced I'm doing the right thing. You can be convinced I'm doing the right thing. But does it persuade an independent third party? Now, that might be the payer in a state system. It might be the NHS. In a private system, it might be the insurer. It might be just a colleague and a peer, but actually it's somebody else saying, I can see what you're doing. We need to be careful about the language and what people are doing. For example, the argumentum ad popularum, lots of people are doing this, therefore it's right. No. We shouldn't be using this. Nobody in any of the medical debates should be using any of these logical fallacies, but we see a lot of them, particularly in the philosophical and literature and in the advocacy literature. And the burden of proof lies on the person who wants to do an intervention. This is a big shock. When I talked to the Royal Society of Medicine gender dysphoria group a long time ago with all the protagonists in the UK there, I was explaining that doing nothing is not doing nothing. Doing nothing skillfully is called judicious non-interference, it's called care, it's called comfort, it's called support. If I want to give you a poison, or if I want to, or somebody wants me to give them a poison or wants me to insult, the burden of proof is on the person doing the intervention, particularly when we're looking at physiology, which is where we start, and then pathology, which we need to explain. I accept that identity is not a pathology. So, back to this third-party question. I know we all would have liked to have done this at school, but we all know you mustn't mark your own homework. And that's the problem with specialist medical societies. We're all very clever. That's why we got into medical school, okay? And that's why they're using artificial intelligence now to help them in their tests. But the thing is, we do know that it's wrong to do that. And there's a fantastic paper by John Ioannidis pre-COVID, before he became vilified, but it's all about why specialist societies should not author guidelines, and it goes through the arguments for that and the evidence why it doesn't work. And also, there's a lot of self-publication in some of the small journals, but also I would particularly point to your attention some of the medical ethical journals. There's a lot of the editors and publishing in their own journals. So we do need to convince third parties, and that's where the issues about evidence come in. So you all know that we've just got to keep calm, ask for evidence. I would strongly recommend Peter Scrabinak's book about follies and foibles in medicine. You can't fail but to see the mistakes. Once you see how mistakes are made, it's very hard not to see them again. And then this is the evidence triangle with meta-analyses of RCTs at the top, and the mechanistic, biological work and case reports at the bottom. Every level of evidence is important, and there's a fantastic paper by Mike Rawlins, who's recently sadly died, and he was the man who set up and was the first chair of NICE, talking about all the levels of evidence and how they interdigitate and why they work. So I would very much strongly recommend that to you. And the point is that cause and effect is only testable in randomized control trials. Pay no attention to before and after. I can't think of a before and after study where after wasn't better than before. I'm just not interested in before and after studies. They are hypotheses generating, precisely nothing else. And evidence obviously has issues to do with settings, the levels of proof, the quality of falsifiability. It diminishes uncertainty. We are all uncertain. Uncertainty is awful, but all we can do is just bring those probabilities in a little bit. So this is the work I was asked to talk about, which is an international clinical practice guidelines for gender minority and trans people, a systematic review and quality assessment. And like a lot of happenstance things, this came out of a medical student project. You got a first for it. And then after the project, we decided to work in a bigger team to actually look at the international transgender health guidelines, because you start, and led by, I want to say, Catherine Meads, who's Professor of Systematic Reviewing, is an absolutely wonderful colleague, and was one of the British government's LGBT health advisors. So I'll just go down a bit because that was the top, but you don't have to read this, because I want you to go and read the paper, because we put a lot of work in. So the citation is there, but I also want to point out that there's another little citation which is to do with what happened next. The thing is that you must start by finding out what you know and what you don't know, because it's the gaps that need to be filled. And I worry sometimes, listening to the language here as well as listening to the language elsewhere, is that some people think research is about proving what you already know. And that is absolutely wrong. You have to go in open-minded, humble, and be surprised. And I love it. But some people don't like being shocked and surprised and having their views challenged. So research is not for everyone. This is a very interesting, very diverse group in age, experience, and sexual orientation and gender identities. And we worked together as a fabulous team, came up with what the most important thing you need to see, which is why I move forward, is that we started with a pre-specified protocol, which we published. And we found things that we were not expecting. So just to show off, we did everything properly. We had a librarian double-check the search, we did double data collection, we did double analysis of whether something was a CPG or not. We decided to have a wide approach, and we took things in that we weren't really sure were, because we thought we'd better just look at everything. And we had 4 aims, and we went through all of them. So we've been through 1.7 thousand abstracts, and we went through masses of different databases, et cetera, but we found 12 clinical practice guidelines that included some kind of recommendation to do with anything to do with transgender health. So that was very interesting. I just want to bring this issue up because of the criticism about stakeholder involvement and the no decision without us. This is very important, this thing about voices and values and preferences. So we did something which not everyone does do, but we actually found all the UK stakeholders. We wrote to all the key opinion leaders in the world to say, are there any clinical practice guidelines we don't know about? And we also wrote to all the organisations saying, we're doing it, and we pointed them to the protocol, and we asked them what their views were. And there was an interesting dichotomy. Actually, it turns out not to be relevant, but there was an interesting dichotomy. The box on the left is the stakeholders, 19 of the 50 we wrote to, and then there's the 6 reviewers on the right. And we all separately prioritised these 6 domains that we've just been hearing about, and you'll see that stakeholders cared passionately about stakeholder involvement, and they weren't so concerned about editorial independence. And we were very concerned about rigour, which we just heard from Ivan, and we weren't so worried about the applicability. It doesn't, as it happens, matter, but there is a divergence of view, and we ought to think about this at all times. So this is just colourful. As Ivan said, don't worry about, we chose slightly different thresholds. We don't want you to be terribly influenced by the colour, but these are the 12 guidelines down in the second column across the 6 domains. In pink, I think, is the stakeholder prioritisation, and in blue, that is the rigour. But what you will see from WPATH is number 1, and I can't read which one is Hembury from here, doesn't matter. 5, thank you. So row 1 and row 5 are the 2 big influential guidelines. And what we were surprised was we found loads of guidelines. Now look at the bottom, all that green. That is the World Health Organization. The World Health Organization does guidelines properly, and they just know what they're doing. And they produce reliable, acceptable guidelines, mostly on the topic of HIV and to deal with transgender women mostly, but others, and so forth. But the very, very poor guidelines were the ones that everyone seems to be using. We didn't recommend them, and that wasn't the point. So here we are. We've used this wonderful Agree tool. It's very good because it's designed for clinicians to use. But what we also did was we went to find, is there any reference in this guideline at all to mortality? Is there any reference at all to quality of life? And then we picked out every single one. We looked at the references, and you can see that we found very, very little on mortality and quality of life. So SOC 7 didn't seem to us to be being a guideline that was doing very much. But worse than that was that we actually finally said we actually made a pre-specified protocol that we were going to compare guidelines. So there's a massive table, if you go to the supplementary appendices, with every single recommendation from every single guideline, because we wanted to see if people were saying the same thing. As it happened, none of them were looking at the same issues. Some were to do with speech therapy, some were to do with penile surgery, one was to do with being nice to cancer patients, some were to do with transition. But basically, there wasn't very much overlap. But in the course of that, when we were trying to extract the recommendations, the first 2 clinicians did not agree on what WPATH was recommending. So without telling the other 4, because we had 6 of us scoring everything at all times, all 6 had read all 12 guidelines, we said, could all 6 people extract the recommendations? And we tabulated everything, and we could not agree what WPATH was saying. And we were trying to find out what WPATH was saying. And that is why, despite being very scientific, very academic, and going through 7 peer reviewers at the BMJ Open, we eventually said that we didn't think this should be gold standard because we couldn't make sense of it. Now, that's rather shocking. I was very shocked. More than that, I was actually very shocked by what wasn't covered. Nothing on primary care, nothing on psychiatric care, nothing on mental health, nothing on long-term health. And we've got many, many trans, non-binary friends, colleagues, patients and citizens, and actually we need to know how to help them in terms of their cardiovascular disease and their bone health and all the rest of us, and they're here for many, many decades to come. And yet the organisations who are in the field seem to be concentrating largely on transition. So anyhow, so the implications, I thought, I've come to my own time, I want to talk to you about decision aids, because this is what's called BRAN, very good for you. BRAN is very good in your diet. Benefits, risks, alternatives, and doing nothing. We should be able to tell people whatever intervention we are doing in medicine, this is the way forward. We're using it in screening. We're using it in decision aids at NICE. You can't have an informed consent without me saying, Julia, if I do a hernia operation, 8 out of 10 you'll be better, 1 you'll be unchanged, 1 you'll be worse. Well, then she said, thank you, now I know what to do. This is the response we got to our paper. We wrote to WPATH, who didn't acknowledge us. We wrote several times because we wanted to be polite and respectful and warn them and say, and they didn't reply, but we know the email got through because firstly, the systematic reviewer said, I've told them about agree to, and I've looked at the evidence anyhow, and we're mentioned, and that's what the letter of response talks about, because we're mentioned in SOC 8 incorrectly. So who marks WPATH's homework? So we've just marked Standards of Care 7. It's interesting that David Gorski has tried to unpick it all, or rather a young trans doctor has done that, and we got miscited and we had a correction. And SOC 8 is apparently the first to use an evidence-based approach, but it isn't. And I've looked at the methods. I'm not interested in the content because the methods are not good enough. So that's a shame, because I think transgender people, and I think that the youth deserve better. And I think lowered standards is a mark of a stigmatized group. We see it in Black patients and a number of stigmatized conditions, mental health particularly. So if you want to know about other work I've done, I'll talk to you in the coffee break. I've looked at a population-based study on auditing primary care because I saw the primary care gap and found that there's no guidelines to audit against. And I've just submitted something with, I think it's 48 papers in, I can't remember the number now. Anyhow, we've done something on transmasculine pregnancy because I'm an obstetrician gynecologist. And I think that's it.